So I'm not seeing too many Hare traction splints when I'm in the emergency department looking at patients that have been brought in by EMS. What are you and your partners telling people about Hare traction? Does it still have a role in emergent fracture management?
Whereas I think there's still a role for it, it is certainly not obsolete. We regard it optimally as a field device and a transport device, meaning that, and it's specifically for femur fractures, whether it's proximal, diaphyseal, or distal. It really is to maintain alignment of the extremity during the occasion to transport a patient to a trauma center. Now, the reason I think it's perhaps a good thing that you're not seeing a lot of it is that I hope we don't have patients down in the emergency room sitting for 8 hours in a Hare traction splint while multiple services evaluate the patient. I think in the past, Hare traction was used out of convenience for probably too long extended periods of time, i.e. the patient comes into the emergency room in a Hare traction splint. They get all their studies, they're seen by 2, 3 services, they go to CAT scan, they're still in the Hare traction splint, they go to the unit, and orthopedic responds, at some point later down the line. That's too long. Hare traction is meant to be a transport device, and what we like to do as soon as orthopedics is involved with the patient is to put the patient in real inline traction through a distal femoral traction pin, and we get the apparatus set up around them with the overhead trapeze on the bed, and so Hare traction is not good for long periods of time because it relies on 2 things. One is compression against the perineum and buttock, and the other is a tourniquet effect around the ankle or supramalleolar region. So this device essentially pushes off the axial skeleton and pulls on the ankle to maintain alignment, and therefore it's not a great thing to have on for a long period of time because it can cause skin problems and a tourniquet effect on the ankle. Really, it's a temporizing device. Correct, yeah.
Another area where I've seen evolution or perceived evolution in orthopedic fracture management is fractures of the clavicle. When I started out, I'm not going to admit how long ago that was, we just used to say put the patient in a sling and they'll stay there until they're comfortable, or 6 weeks or 8 weeks, and only, I think, if they had significant symptoms did we worry about early orthopedic involvement. What I'm seeing from your service now is very different from that, and you seem to be much more aggressive in operating on these patients.
And multiple studies now corroborate what we thought we were starting to find out with retrospective work, that patients are more satisfied with the cosmetic appearance of a scar rather than a big lump in the supraclavicular region, A. B, have measurable and quite significant differences in function as they perceive it with functional outcome tools. C, their measurable range of motion and strength measured with a handheld dynamometer or a Cybex machine, different side to side. And so the opportunity to approach or be normal after open reduction internal fixation is much more likely than with non-operative treatment. And specifically, we've looked at how much displacement warrants an operation. 2 centimeters of medialization is absolutely associated with higher unacceptable malunion rate, higher non-union rate, and lower function and lower strength and increased fatigability, particularly with overhead activities.
So I'm in a rural setting now. A patient comes with a clavicular fracture. I'm suspicious. How soon would you want to see that person in the office? And when would you think about, what's your window for surgery in those patients? Do you wait a period of time, or if you identify an appropriate fracture, do they need to get to the operating room right away?
Well, there's no urgency. I can see it in a week, I can see it in 2 weeks. There's a role for fixing fractures as soon as you identify that the patient's an appropriate candidate for fixation. So it can be done the next day if you recognize it and you're able to have the resources to get it in the OR. But there's no problem doing it a week or two later.